Functional dyspepsia, FD, is a chronic disorder characterized by upper abdominal discomfort or pain that persists for at least 3 months, without an identifiable structural, metabolic, or inflammatory cause on routine investigations, such as endoscopy or imaging. Patients typically report a sensation of early fullness, postprandial bloating, or burning that is not explained by peptic ulcer disease, gastroesophageal reflux, or malignancy. For example, a 42-year-old office worker may feel a heavy, uneasy feeling after a normal lunch, and despite normal endoscopic findings, the symptoms continue, fulfilling the functional criteria. Several gut-derived hormones orchestrate hunger, gastric acid secretion, motility, and satiety. Ghrelin released mainly from the fundus stimulates appetite and promotes gastric emptying. Gastrin produced by G cells in the antrum drives acid secretion and enhances motility. Motilin secreted by the duodenum triggers phase 3 migrating motor complexes that clear the stomach during fasting. Cholecystokinin, CCK, and peptide YY are released postprandially to slow gastric emptying and signal satiety. Dysregulation of any of these hormones can disrupt the delicate balance between gastric accommodation and propulsion, leading to the hallmark symptoms of FD. Functional dyspepsia affects roughly 10 to 20% of adults worldwide, making it one of the most common reasons for primary care visits for gastrointestinal complaints. The condition carries substantial indirect costs, lost workdays, reduced productivity, and impaired social functioning due to avoidance of meals. Direct healthcare expenditures are also high because patients often undergo repeated endoscopic evaluations, laboratory testing, and empirical medication courses despite limited benefit. In many healthcare systems, FD ranks among the top contributors to gastroenterology outpatient workload. When ghrelin levels are inappropriately high, patients may experience heightened hunger with rapid gastric emptying, producing early satiety sensations because the stomach empties before a normal satiety signal can develop. Elevated gastrin amplifies acid output, potentially sensitizing the mucosa and provoking burning. Low motilin impairs the fasting motor complex, leading to delayed clearance of gastric contents and postprandial fullness. Excess CCK, or PYY, prolongs the inhibitory phase of gastric emptying, producing a sensation of bloating and nausea. Clinical studies have documented that subsets of FD patients have measurable deviations in these hormone concentrations compared with healthy controls. Visceral hypersensitivity refers to an exaggerated neural response to normal gastrointestinal stimuli. In FD, mechanoreceptors in the gastric wall become sensitized, so a modest distension that would be unnoticed in a healthy individual produces pain or discomfort. For instance, a small amount of intragastric gas may be interpreted as a sharp cramp. This phenomenon is often assessed using balloon distension tests, where FD patients report pain at lower pressures than controls. Central nervous system mechanisms, such as reduced descending inhibition, also contribute to this heightened perception. Altered gastric emptying in FD can manifest as either delayed or accelerated transit. Delayed emptying prolongs contact between gastric contents and the mucosa, leading to sustained distension, fullness, and nausea. Accelerated emptying may cause rapid delivery of chyme to the duodenum, triggering premature satiety and reflux-like symptoms. Scintigraphic studies have shown that roughly 30% of FD patients have objectively delayed emptying, while another 15% display rapid emptying, underscoring the heterogeneity of the disorder. Psychological stress activates the hypothalamic pituitary adrenal axis and the sympathetic nervous system, releasing cortisol and catecholamines that modulate gastric motility and hormone secretion. Acute stress can induce a gut-brain stress response, resulting in a sensation of a knot in the stomach, early satiety, or heightened pain perception. Long-term anxiety correlates with increased somatic vigilance, making patients more attuned to benign gastric sensations and thereby amplifying symptom reporting. Cognitive behavioral interventions that reduce stress have been shown to improve FD symptom scores in randomized trials. Specific dietary components can provoke FD symptoms by irritating the gastric mucosa or altering hormone release. High-fat meals stimulate CCK, slowing gastric emptying and increasing fullness. Spicy foods may provoke gastrin release, augmenting acid secretion. Lactose intolerance can lead to bloating and gas production, exacerbating visceral hypersensitivity. A structured food challenge diary, recording meals, symptoms, and timing, helps identify individual triggers, enabling personalized dietary modification. H. pylori colonizes the gastric mucosa in up to half of the world's population. While many carriers remain asymptomatic, the bacterium can increase gastrin secretion and induce chronic low-grade inflammation, which may aggravate FD symptoms. Eradication therapy, clarithromycin-based triple therapy, has demonstrated modest but significant improvement in dyspeptic symptoms in H. pylori-positive FD patients, suggesting that the infection acts as a disease modifier rather than a primary cause. Family aggregation studies indicate that first-degree relatives of FD patients have a 2 to 3-fold higher risk of developing the disorder. Genome-wide association studies have identified polymorphisms in genes related to serotonin transport, SLC6A4 cytokine regulation, IL-1 beta, and gastric hormone receptors, GHSR for ghrelin, that may influence susceptibility. These genetic variants can affect neural processing of visceral signals, gastric motility, or inflammatory pathways, predisposing carriers to functional dyspepsia. The neurohormonal axis comprises bidirectional communication between the central nervous system and the gastrointestinal tract via the vagus nerve, spinal afferents, and circulating hormones. Disruption of this axis, whether through altered vagal tone, abnormal hormone release, or central sensitization, leads to mismatched signaling. For example, reduced vagal afferent input can diminish postprandial satiety signals, while heightened central pain amplification increases the perception of normal gastric distension, producing the classic FD symptom complex. Gastric accommodation is the fundus's ability to relax and expand in response to an incoming meal, allowing the stomach to hold food without a rise in intragastric pressure. In FD, this reflex is often blunted, so even a modest meal creates a disproportionate pressure rise, perceived as early satiety or fullness. Baristat studies have quantitated reduced maximal accommodation volumes in up to 40% of FD patients, correlating with symptom severity. Delayed emptying gastroparesis leads to prolonged gastric distension, nausea, and postprandial fullness, often worsening after high-fat meals. Accelerated emptying rapid transit results in swift, chyme delivery to the duodenum, triggering early satiety and sometimes reflux. Breath test and scintigraphic assessments differentiate these patterns, guiding therapy. Prokinetics for delayed emptying and dietary modification, low glycemic index for rapid emptying. Central sensitization involves heightened responsiveness of spinal and supraspinal neurons to peripheral input. In FD, functional MRI studies reveal increased activation of the anterior cingulate cortex and insula during gastric distension, suggesting that the brain amplifies visceral signals. This phenomenon explains why patients experience severe pain from modest gastric stimuli and why treatments targeting central pathways, for example low-dose tricyclic antidepressants, can alleviate symptoms. The HP axis mediates the body's response to stress by releasing corticotropin-releasing hormone, ACTH, and cortisol. Chronic activation raises cortisol levels, which can increase gastric acid output, impair mucosal protection, and modify gut hormone secretion. For example, suppress ghrelin. Over time, this creates a hyperreactive gastric environment, contributing to the persistence of dyspeptic symptoms. Salivary cortisol measurements in FD cohorts often correlate with symptom severity. The enteric nervous system, ENS, contains a dense network of sensory, motor, and interneurons that regulate motility, secretion, and blood flow. Gut hormones act as neuromodulators, binding to receptors on ENS neurons to fine-tune these functions. For example, CCK binds to CCK1 receptors on vagal afferents, slowing gastric emptying, while ghrelin activates growth hormone secretagogue receptors on myenteric neurons, promoting motility. Dysregulation of either component disrupts coordinated gastric activity, manifesting as functional dyspepsia. Epidemiological surveys estimate that 5 to 20% of adults worldwide meet Rome 4 criteria for functional dyspepsia. Prevalence tends to be higher in Western industrialized nations, up to 22%, compared with certain Asian countries approximately 5 to 10%, reflecting differences in diet, healthcare access, and possibly genetic background. Functional dyspepsia shows a modest female predominance, approximately 1.3 to 1, and most frequently presents in individuals aged 30 to 50 years. This pattern parallels other functional gastrointestinal disorders, suggesting shared hormonal and psychosocial risk factors. Regional differences in FD prevalence are thought to arise from variation in dietary patterns, for example, high-fat Western diets versus low-fat Asian diets, prevalence of H. pylori infection, cultural attitudes towards symptom reporting. Up to 50% of FD patients also meet criteria for irritable bowel syndrome, functional constipation, or gastroesophageal reflux disease. This overlap suggests common pathophysiological mechanisms, such as visceral hypersensitivity and dysregulated gut-brain signaling. Patients describe a burning or aching sensation localized to the epigastrium that may be present fasting or after meals. Unlike classic heartburn, the pain does not radiate to the chest. For example, a person may experience annoying discomfort after a light breakfast that resolves after a few hours. Early satiety is the perception of fullness after consuming a small amount of food, often leading the patient to stop eating prematurely. Clinically, a patient might set down a sandwich after taking only one bite because continued eating feels intolerably heavy. Postprandial fullness is a persistent, uncomfortable sensation of heaviness or distension that persists for several hours after eating. It differs from early satiety in that the patient can finish a normal portion, but the feeling of a full stomach lingers, often accompanied by bloating. Bloating refers to the subjective feeling of abdominal swelling, often accompanied by visible distension. It may result from excess intraluminal gas, delayed emptying, or altered viscerosensory processing. Patients frequently report that their clothes feel tighter after meals. Nausea is an uneasy sensation in the upper abdomen that may precede vomiting. In FD, nausea commonly follows large or fatty meals and may be intermittent. While overt vomiting is less common, occasional emesis can occur during severe symptom flares. Patients with FD frequently experience abdominal pain, bloating, and altered bowel habits, diarrhea, or constipation typical of IBS, making diagnostic delineation challenging. This comorbidity reflects shared mechanisms such as visceral hypersensitivity and central sensitization. Rome 4 requires the presence of at least one of the following for the past 3 months, with onset at least 6 months earlier, and no evidence of structural disease. Postprandial fullness, early satiety, epigastric pain, epigastric burning, These symptoms must occur at least once weekly. Before diagnosing functional dyspepsia, clinicians perform upper endoscopy esophagogastrodiodnoscopy to rule out peptic ulcer disease, malignancy, or severe gastritis. In some cases, abdominal ultrasound or CT may be ordered to exclude gallbladder disease or pancreatic pathology. A normal endoscopic and imaging workup supports the functional diagnosis. Non-invasive H. pylori detection, urea breath test stool antigen serology, is recommended in FD patients because eradication can improve symptoms. In research settings, fasting gastric hormone levels, for example ghrelin-gastrin, may be measured to identify hormonal phenotypes, although routine clinical use is limited. Gastric emptying scintigraphy is the gold standard, but a 13C octanoic acid breath test offers a non-radioactive alternative. After ingesting a labeled meal, the rate of 13CO2 appearance in exhaled breath reflects gastric emptying speed. Results guide therapy, prokinetics for delayed emptying, dietary modification for rapid emptying. Functional MRI and positron emission tomography, PET, are used in research to visualize brain activation patterns during gastric distension or symptom provocation. They have identified hyperactivation of the insula and anterior cingulate cortex in FD, supporting the role of central processing in symptom generation. PDS is a Rome-4-defined FD subtype dominated by meal-related symptoms: early satiety, postprandial fullness, and epigastric pain burning that occurs shortly after eating. Management focuses on dietary modification, prokinetics, and therapies targeting gastric accommodation. EPS is characterized by persistent epigastric pain, or burning that may be unrelated to meals. The pain is often described as gnawing, dull, or burning, and may be continuous or intermittent. Acid suppression therapy PPIS frequently benefits this phenotype. In this phenotype, measurable hormonal abnormalities, for example elevated fasting ghrelin or gastrin, dominate the clinical picture. Patients often respond better to targeted hormone modulating agents, such as ghrelin antagonists for high ghrelin or gastrin receptor blockers for hypergastrinemia. Most FD patients exhibit a combination of mechanisms: partial hormonal dysregulation, modest hypersensitivity, and variable emptying abnormalities, requiring a multimodal therapeutic approach. Recommended lifestyle changes include eating 3 regular balanced meals, avoiding large meals, and chewing slowly. Setting a 20-minute timer for each meal helps prevent rapid ingestion, which can overstretch the stomach and trigger symptoms. PPIS, for example, omeprazole and esomeprazole, reduce gastric acid secretion by irreversibly inhibiting the H+K at pace pump. They are especially effective in EPS patients, where acid hypersecretion contributes to burning pain. Prokinetics enhance gastric motility. Domperidone blocks dopamine D2 receptors, increasing gastric contractility without crossing the blood-brain barrier, thus reducing side effects. Low-dose erythromycin acts as a motilin receptor agonist, stimulating phase 3 MMCS and accelerating emptying in patients with delayed gastric transit. Emerging agents aim to correct specific hormone imbalances. Ghrelin agonists, for example relamorelin, accelerate gastric emptying. Ghrelin antagonists may reduce hyperhunger states. Gastrin receptor antagonists, for example nedazepide, lower acid output. Clinical trials show promise for symptom reduction in hormone-predominant FD subsets. Low-dose tricyclic antidepressants, for example amitriptyline, and SSRIs, for example escitalopram, modulate central pain pathways and improve visceral analgesia. They are particularly useful when central sensitization or comorbid anxiety/depression is present. Cognitive behavioral therapy teaches patients to identify and modify maladaptive thoughts about symptoms, reducing stress-induced gut responses. Gut-directed hypnotherapy employs guided imagery to promote relaxation of the gastrointestinal tract, decreasing visceral hypersensitivity. Probiotics, for example Lactobacillus rhamnosus, may modulate the gut microbiota, indirectly influencing hormone release and inflammation. Herbal agents such as peppermint oil, a smooth muscle relaxant, and ginger, an anti-nausea, are frequently used adjunctively, though evidence varies. Measuring fasting ghrelin, gastrin, and CCK levels in newly diagnosed FD patients can uncover hormonal phenotypes before chronic symptom entrenchment. Early detection allows clinicians to select targeted therapies, for example, ghrelin agonist, rather than trial and error approaches. Techniques such as deep breathing, progressive muscle relaxation, mindfulness meditation, and yoga have been shown to lower cortisol and improve heart rate variability, leading to reductions in dyspeptic symptom scores in randomized trials. Consuming meals with moderate macronutrient distribution, approximately 30% protein, 30% fat, 40% carbohydrates, at regular intervals, stabilizes postprandial hormone release, for example reduces exaggerated CCK spikes, and supports gastric accommodation. Caffeine and alcohol increase gastric acid secretion and can aggravate gastrin release. NSAIDs impair mucosal defensive mechanisms, heightening susceptibility to irritation. Advising patients to limit these agents often results in noticeable symptom improvement. Functional dyspepsia is generally chronic. However, longitudinal studies indicate that 30 to 40% of patients achieve periods of remission, especially after comprehensive lifestyle and pharmacologic interventions. Relapse is common if triggers reappear. Persistent dyspeptic symptoms can lead to reduced social eating, anxiety about meals, and depressive symptoms. Validated questionnaires consistently show lower scores in physical and mental health domains compared with the general population. Observational cohorts suggest that patients receiving hormone-targeted agents, for example ghrelin agonists, experience higher rates of sustained symptom relief over 12-month follow-up than those treated with standard PPIs or prokinetics alone. However, larger randomized trials are still needed to confirm these findings. New synthetic ghrelin receptor agonists, for example relamorelin and ulamorelin, are under investigation for their pro-kinetic properties. Early phase 2 trials demonstrate accelerated gastric emptying and reduced nausea in FD patients with delayed emptying, offering a promising therapeutic avenue. Research aims to define specific hormone signatures, for example, high fasting CCK, low ghrelin, that predict response to particular drugs. Such biomarkers could enable precision medicine, moving away from the current trial and error paradigm. Animal models show that certain microbial metabolites, short-chain fatty acids, stimulate PYY and GLP-1 release, influencing satiety and motility. Human studies are exploring whether probiotic-induced microbiome shifts can normalize dysregulated hormone patterns in FD. Advanced imaging, fMRI, resting state connectivity, reveals altered functional connectivity between the insula, anterior cingulate cortex, and somatosensory regions in FD, correlating with visceral hypersensitivity scores. These insights support the development of neuromodulatory interventions, such as transcranial magnetic stimulation. Future clinical pathways may incorporate hormonal phenotyping, for example, ghrelin high, CCK low, alongside genetic data to assign patients to the most effective therapy, mirroring precision oncology.